Hello everybody. So welcome to the 10th video of my series, and I know it's been a long wait, but yeah, I was a bit busy with all the my college starting. Anyway, so this is my 10th video, and over here we'll be discussing the beta 2 agonists. Now we all know that the beta 2 agonists, their primary role is in certain pulmonary conditions like bronchial asthma and COPD, that is chronic obstructive pulmonary disease. Now, if we are to look at the physiology of a bronchial smooth muscle cell, so imagine this is a bronchial smooth muscle cell. They have these two receptors. This is an M3 receptor, that is a muscarinic receptor type 3, and they also have a beta 2 receptor. There's a beta 2 adrenergic receptor. When the M3 receptor is stimulated, there is an increasing intracellular calcium, which leads to bronchoconstriction. And when there is stimulation of the beta 2 receptors, there is an increase in cyclic AMP, which leads to bronchodilation. Another thing is that cyclic AMP is broken down by an enzyme which is phosphodiesterase 3 or 4. Okay, so from this we can easily we can draw a reasonable assumption as to what drugs may be used for the treatment of these pulmonary conditions. So number one, we can give an M3 blocker. Okay, so the intracellular calcium levels go down and the bronchial smooth muscle cells relax. Also, we can give a beta 2 agonist, increases cyclic AMP levels, causing bronchodilation. Also, we can give phosphodiesterase inhibitors, and which will of course maintain a steady level of intracellular cyclic AMP, resulting in bronchodilation. So, the class of drugs we are going to discuss here today are the beta 2 agonists. So the first thing that you need to remember about the beta 2 agonists is that they are best delivered by inhalational route. The question is why? Well, you can make a reasonable guess. That is, it will have greatest local effect on the bronchial smooth muscle. Also, there will be least systemic toxicity. Because of these two reasons, they are best delivered by inhalational route. Now there are three classes of these beta 2 agonists. Let's discuss them one by one. So the first class is called SABA. The second class, LABA. The third class, VLABA. So what is SABA? These are the short acting beta agonists. What is LABA? These are the long acting beta agonists. And VLABA, these are the very long acting beta agonists. Let's learn their names first. So, short acting beta agonists include terbutaline, then there is berbuterol, there is albuterol, also known as salbutamol, and there is metoprolol. Of these, terbutaline can be given by subcutaneous route, 0.25 milligrams. Okay, this is important. Now the long-acting beta agonists include salmeterol and formoterol. And the very long-acting beta agonists include indicaterol, olodaterol, vilanterol, bambuterol, and carmoterol. So when I am saying that these are short acting, what I mean to say that is that the duration of action is just 2 to 4 hours. The long acting have a duration of action of nearly 12 hours, and the very long acting have a duration of action of 24 hours. Okay. Now the next is the uses. All the SABA drugs can be used in the treatment of an acute attack of bronchial asthma, and in fact the drug of choice is, as you know it, is salbutamol. There's a very interesting thing about salbutamol is that it is believed that the R isomer activates the beta 2 receptor, and there is a fear that the S isomer actually causes bronchial inflammation and edema, thereby worsening the asthma. And so a purified preparation of the R isomer is available, and that is known as lev-albuterol. Okay, so it's nothing, just the R isomer of albuterol. In an acute attack of bronchial asthma, we can also give a long-acting beta agonist, and that is formoterol. But of course, the drug of choice will always remain salbutamol. Now, the next thing we have to discuss are the LABAs. Now, the LABAs are primarily given as BD dosing in the treatment of persistent bronchial asthma, and of course it is combined with inhalational corticosteroids. I'll be discussing the inhalational corticosteroids later. They got flunarizide, fluticasone, budesonide, cyclophosphamide, these drugs. And also, they're given in COPD, but again in combination with anticholinergics. The VLABAs, well, they are used only for the treatment of COPD, and they are given by OD dosing. Now I discussed about the inhalational route. Now salbutamol can also be given by oral route, and oral salbutamol is given as prophylaxis against nocturnal bronchial asthma. Okay. Now there is one more thing that we need to discuss about the beta 2 agonists is that there is a single nucleotide polymorphism effect on the action of beta 2 agonists. The gene which encodes for the beta 2 receptors, there is a single nucleotide polymorphism at the codon at position 16, and this leads to deterioration of the asthma control, when beta 2 agonists are given. Okay. Another concern is that they also sometimes induce tachyphylaxis. Yeah, tachyphylaxis. Now, what is tachyphylaxis? It is a form of drug resistance. I'll be discussing it in detail in a later video. Just for now, know that there is a risk of induction of tachyphylaxis with beta 2 agonists. But of course, these are very rare side effects. The common ones are, so here we are discussing the side effects. Tremors, which is in fact the most common side effect. There can also be palpitations, hyperglycemia, and the mechanism for this hyperglycemia, I hope you remember the pharmacological basics video. What is the mechanism for this hyperglycemia? Then there can be transient hyperkalemia, due to potassium channel blocking effect, followed by hypokalemia due to insulin release. Yeah, so this hyperglycemia is stimulating the insulin release, and of course there can be QT prolongation. Okay, so these side effects are very important, because in a patient, if you're treating for bronchial asthma, if you the patient may develop tremors, and it's in fact the most common side effect. There can be palpitations, hyperglycemia, transient hyperkalemia followed by hypokalemia, and of course QT prolongation. So these side effects are very important, especially when you're treating an asthmatic, because in commonly in an asthmatic patient there can be various comorbidities as well. So these side effects have to be kept in mind. And yeah, so this single nucleotide polymorphism, you might not remember because it's rarely asked, this, but yeah, the one of the mechanisms of resistance of against these beta 2 agonists is due to the single nucleotide polymorphisms found in certain individuals. And also, yes, this induction of tachyphylaxis, I'll be discussing this mechanism in a later video. Okay, the more important questions which are asked from this portion are the names of these drugs, and the routes of administration. All are given by inhalational route. Terbutaline can be given as subcutaneous, salbutamol as an oral, and of course their uses in COPD and bronchial asthma. And this just keep a very basic idea about the physiology of the bronchial smooth muscle cell, because that is the mainstay of the pharmacotherapy of acute bronchial asthma. And of course, why is it best delivered by inhalation route? So yeah, these are the common questions which are asked from this portion. Thank you.